Welcome back to Roadmap to Residency. Today we are tackling one of the highest yield topics on Step 2, common solid tumors. We will cover lung, colorectal, breast, and prostate cancer, plus 2 oncologic emergencies you absolutely must recognize on test day. Instead of teaching every detail of each cancer, we are going to walk through board-style questions and show you exactly how to think, how to spot the trap answers, and how to lock in the right choice. Let us get started. Here is what you will walk away with after this video. First, you will recognize the classic question stems for the 4 big solid tumors. Second, you will know the test-taking strategy for picking the right screening test or the right next step. Third, you will be able to spot 2 oncologic emergencies and know what to do first. And fourth, you will have practiced several multiple-choice walkthroughs so you know not just the right answer, but why the distractors are wrong. That last part is what separates a good score from a great score. Every oncology question on Step 2 can be attacked with the same 3-step framework. Step 1. Find the demographic and the risk factors. An older smoker is lung cancer until you prove otherwise. An average risk adult past age 45 needs colorectal screening. A postmenopausal woman with a new breast mass is breast cancer until imaging and biopsy say otherwise. Step 2. Find the red flag finding. Hemoptysis, weight loss, iron deficiency anemia, back pain worse at night. These are the words that flip the question. Step 3. Pick the next step. For suspected cancer, the answer is almost always tissue. For screening, match age and risk to the tool. For emergencies, stabilize and image. Use this framework on every question and your accuracy will climb. Let us drill the buzzwords fast, because these are what the test uses to point you toward the diagnosis. A heavy smoker with hemoptysis, weight loss, or a new supraclavicular node is lung cancer. Hoarseness, or a dropped eyelid with a small pupil points you to an apical tumor. Iron deficiency anemia in an older man or a change in bowel habits is colorectal cancer. Remember, right-sided colon lesions bleed, left-sided colon lesions obstruct. For emergencies, facial swelling and distended neck veins in a smoker is superior vena cava syndrome. New severe back pain with leg weakness in a known cancer patient is cord compression until proven otherwise. Memorize these and you will recognize the question before you finish reading it. Let us work through our first question. Read the stem with me. A 68-year-old man, heavy smoker, 3 months of cough, 10 pounds of weight loss, and 1 episode of blood-streaked sputum. Chest radiograph shows a 3-centimeter mass in the right upper lobe. What is the next step? Take a moment to pick your answer from A, B, C, or D before we walk through it. Let us break this down. The stem is giving you every red flag for lung cancer: heavy smoker, weight loss, hemoptysis, and a mass. Do not get tricked by the word bronchitis or pneumonia in your head. The question is asking about a suspicious mass, which needs tissue. Choice A. Repeat the chest film in 6 weeks, delays a cancer diagnosis, never correct when cancer is on the differential. Choice B, empiric antibiotics, assumes infection, but there is no fever, no consolidation, and there is weight loss plus hemoptysis. Wrong. Choice D, start chemotherapy, skips the diagnosis entirely. You cannot treat a cancer you have not proven or staged. The correct answer is C. Computed tomography characterizes the lesion and looks for spread, and biopsy gives the cell type. The rule to carry into every question: imaging finds it, biopsy proves it, staging guides it. For deeper review, flip to the pulmonary oncology section of your main review book and do a UWorld block on lung cancer. Second question, read carefully. A healthy 46-year-old woman, no symptoms, no family history, asks about colorectal cancer screening. She wants the least invasive option that is still recommended first line. Which do you pick? Remember, the stem is telling you what to optimize for. Do not answer the question you expect. Answer the question that was actually asked. This is a test-taking trap that catches a lot of students. Let us decode it. She is 46, she is average risk. Current guidelines start average risk colorectal screening at age 45, so choice A is out. Both colonoscopy and annual stool-based testing are recommended first-line options, but the STEM specifically asked for the least invasive option. Colonoscopy requires bowel prep and sedation. A stool-based test like a fecal immunochemical test requires neither, so the correct answer is C. Choice D, flexible sigmoidoscopy alone, is not preferred as a sole strategy. The lesson here is huge for test day. Always read what the question is optimizing for. Least invasive, most definitive, most cost-effective, and best initial are all different asks. Let the verbs in the question tell you which answer wins. For more on screening intervals, check the preventive medicine section of First Aid and the Colorectal Cancer chapter in Master the Boards. Breast cancer shows up in two flavors on Step 2, the screening question and the diagnostic question. For screening, know that mammography starts at age 40 to 50, depending on the guideline, and continues every 1 to 2 years through age 74 in average risk women. A strong family history or a known genetic mutation moves screening earlier and adds magnetic resonance imaging. For a palpable mass in any woman over age 30, the pathway is always ultrasound plus mammography, followed by core needle biopsy. On test day, any suspicious breast finding leads to biopsy. Do not be fooled by answers that say repeat imaging in 6 months when a mass is palpable. And remember, hormone receptor status and the human epidermal growth factor receptor 2 status drive therapy and are high yield. Review breast cancer in the Oncology chapter of your main review book and in any focused UWorld block. Third question. A 55-year-old man, prostate-specific antigen of 6.2, and a firm nodule on digital rectal exam, no urinary symptoms. What is next? Pick your answer now, then we will walk through it together. 2 findings flip this question from screening to cancer workup. The prostate-specific antigen is above 4. The digital rectal exam shows a firm nodule. Either finding alone could prompt a biopsy discussion, but together they make the answer clear. Do not be fooled by the lack of urinary symptoms. Early prostate cancer is usually silent. Choice A, repeat the prostate-specific antigen in a year. Delays diagnosis in a patient with a suspicious nodule. Wrong. Choice B, alpha blocker and reassurance, treats benign prostatic hyperplasia, which does not cause a firm nodule. Wrong. Choice D, immediate surgery, skips diagnosis and staging. Never correct. The answer is C. Biopsy is required before any treatment. The universal rule, no treatment without tissue. Review prostate cancer in Master the Boards Urology and in UWorld prostate blocks. Fourth question, and this one is an emergency. A 62-year-old heavy smoker with 2 weeks of progressive facial swelling, distended neck veins, bilateral arm swelling, and a right paratracheal mass on chest film. He is stable. What is your next step? Take a moment, then we will break it down. This is a classic presentation of superior vena cava syndrome. Facial swelling, distended neck veins, bilateral arm swelling, smoker, mediastinal mass. The most common cause on the boards is lung cancer, followed by lymphoma. First question, is the patient stable? Stridor, altered mental status, or hemodynamic instability means airway or brain edema and demands immediate intervention with radiation, stenting, or airway management. This patient is stable, so you have time to image, get tissue, and plan. Choice A treats heart failure, which is the wrong diagnosis. Choice C jumps to radiation without tissue, which is wrong because treatment depends on cell type. Choice D misses an emergency. The correct answer is B. Image with computed tomography, give corticosteroids as a bridge to reduce edema, and arrange tissue diagnosis. Review oncologic emergencies in the First Aid Oncology chapter. Fifth and final question. A 58-year-old man with metastatic prostate cancer, 4 days of mid-back pain that is worse at night, new bilateral leg weakness, and difficulty urinating. Sensory level at the umbilicus. What do you do now? This is the kind of question that separates high scorers from everyone else. Pick your answer. Then we walk through it. This is spinal cord compression, and it is a neurosurgical emergency. Known cancer plus new back pain plus weakness plus urinary change equals cord compression until proven otherwise. Pain worse at night and a sensory level seal it. Every hour of delay means more permanent neurologic damage. Choice A, plain films, cannot exclude cord compression. Wrong. Choice B, outpatient follow-up is dangerous here. Wrong. Choice D, bone scan, evaluates metastases but does not address the cord. Wrong. The answer is C, give intravenous corticosteroids immediately to reduce cord edema, then magnetic resonance image the entire spine because lesions are often multiple. Definitive treatment is radiation, surgery, or both. If this walkthrough helped you, please hit the like button and subscribe to the Roadmap to Residency channel for more high-yield Step 2 content. For one-on-one expert tutoring and residency advising from our team, visit roadmaptoresidency.com. We will see you in the next video.